Hello, my name is Allison, and I'm a nursing student at the University of Michigan, Ann Arbor. Today, I will be giving a full patient report on patient X, a 19-year-old single Caucasian female student studying literature, science, and the arts at the University of Michigan. Patient presents with chest pain between Erb's point and aortic areas of the heart, with periodical radiation up to her neck. Patient was diagnosed with hypermobility dysautonomia and a heart block, which only occurs during sleep in March of 2014 at age 17. Hypermobility dysautonomia is a rare neurological disorder affecting the autonomic nervous system. However, in the case of the patient, causes constant hypertension, localized chest pain, and palpitations. The patient's normal blood pressure is 130/92, and her normal resting heart rate is 91 beats per minute. During episodes of her disorder, her blood pressure can rise as high as 140/95. And the patient will then take her hypertension medication called enalapril, which she takes as needed. Overall, patient X is satisfied with her general health and is experienced in handling her episodes that occur between once a week and once every couple of months. In her disorder, patient X has found herself unable to eat meat, and sometimes goes a full day without knowing she is hungry. When asked to explain more, the patient described how some days she goes without eating, simply because she has no signal of hunger. And other days, she is always hungry and will not stop eating or snacking throughout the day. Her sleep schedule is also abnormal, with her waking up about 5 or 6 times each night, but manages to get at least 7 hours of sleep. The patient's tendency to sleep also rises during periods of hypertension. The patient will develop intolerable headaches and will gradually progress into a migraine if not managed properly. These periods of hypertension drain her energy and cause lightheadedness and usually ends in the patient falling asleep due to emotional and physical exhaustion. When asked what makes her episodes better or worse, the patient says that eating salty foods, dehydration, and the consumption of alcohol make her symptoms worse, while the only thing that truly makes her feel better is sleep. Patient X also does not drink caffeine because it induces symptoms, and she already has trouble sleeping. Patient X has a family history of heart problems. Her maternal grandfather passed away of a heart attack at age 52. He was also a smoker. Her parental grandfather died of a heart attack due to diabetes that was not well taken care of. Her maternal grandmother developed hypertension later in life, and her paternal grandmother died of breast cancer. Parents are healthy with no history of illness. Patient X has been to the emergency room 3 times for her illness, but has only been admitted once in March of 2014 for 4 days due to an inability to stabilize her blood pressure. The patient is allergic to Cefzil, an antibiotic in which she broke out in hives once in 7th grade. She also suffers from seasonal allergies, but takes over-the-counter remedies for relief. Patient has not had a recent spell of weight loss or gain, and does not have a cold intolerance. However, recently she has noticed that when she is ill with a cold, she almost always has a 100-degree Fahrenheit fever. Due to my patient's condition and health history, I chose to perform a review of symptoms and exam on the cardiovascular and peripheral vascular systems. First, I will begin with the overall review of the cardiovascular system. The patient has chest pain, usually located in the upper left portion of the chest, between Erb's point and aortic point. Occasionally, this pain will radiate up to the neck, but this normally happens during her episodes and is not consistent otherwise. Patient has hypertension with a usual resting blood pressure of 130/92 and a heart rate of 91. Patient experiences heart palpitations due to her disorder and was also diagnosed with a heart block, which normally occurs at night. In this situation, her heart enters bradycardia and sometimes skips a beat while she sleeps. She goes in once a year to her cardiologist for testing. The patient exercises 4 to 5 days per week and normally is very fatigued during and after, feeling as though she is always out of shape even when she's in the best shape of her life. During exercise, her heart rate immediately increases to about 160 to 200 beats per minute, and then it evens out during exercise. This heart rate usually takes time to return to her normal resting heart rate of 91 beats per minute. Patient does not feel any additional feelings of fatigue and does not have any problems lying flat on her back. The review of the peripheral exam was done mainly in accordance to checking the patient's peripheral blood flow due to her heart condition. The patient feels pain in her hips when walking, and her femur will occasionally pop out of her acetabulum, causing inflammation and discomfort. The patient normally rests when this happens, and does not ingest any NSAID and anti-inflammatories for relief. An interesting aspect of her disorder is the ability of being double-jointed in almost all joints, and this ability comes into play during the movement of her hips and legs, no matter the extent of exertion. The patient also feels tingles in her hands and feet. which are described as a spider-crawling tingling sensation. Patient also reports coldness in her outer extremities and almost always feels cold. Patient has no history of thrombosis in her legs and no history of varicose veins. Moving on to the cardiovascular exam portion, I discovered no abnormalities besides from a high heart rate when auscultating the apical pulse. During inspection, I noticed no sign of heaves or lifts over any of the 5 key areas, and during palpation, there were no noticeable lifts or thrills, and no divergence of pace in the PMI in relation to other key areas. S1 and S2 heart sounds were present, and there were no additional heart sounds such as S3 or S4, and there is no presence of a heart murmur. The patient's heart is healthy and of normal range. The only abnormality is her cardiovascular system is her hypertension and tachycardia brought on by her neurological disorder. Moving on to the peripheral vascular exam, the patient's peripheral pulses were all 2+, with the popliteal pulse being 1+, considering it is one of the deeper peripheral pulses to palpate. When inspecting and palpating the upper and lower extremities, I noticed the skin temperature was on the cold side. When I asked the patient, she reported that she often feels cold in her outer extremities and almost always feels cold. Other than temperature being a little cold, there is no sign of edema, tenderness, lesions, or varicosities. Capillary refill on both the fingers and toes are all less than 2 seconds. Nails were healthy with pink undertones, were convex shaped with no sign of clubbing, and were attached cleanly in the nail bed. In addition to the cardiovascular and peripheral vascular systems, other pertinent exams to patient X's condition are neurological and respiratory. I chose neurological because her condition, hypermobility dysautonomia, is a neurological disorder affecting her autonomic nervous system. However, in the case of the patient, it affects her heart rhythm. According to the article from the scholarly journal Indian Pacing and Electrophysiology, the dysautonomia portion of the syndrome causes an increase of heart rate of more than 30 beats per minute, or a heart rate greater than 120 beats per minute when a change from supine to upright position is performed. Considering the patient has a resting heart rate of 91 and an active heart rate of 160 to 200 beats per minute during exercise, this definition of dysautonomia is highly accurate in relation to patient X. In respect to the review of the neurological system, the patient has no history of seizures or loss of consciousness, and no concern about memory or ability to concentrate. The patient has difficulty staying asleep and wakes up on average 3 to 5 times per night, but is negative for other neurological symptoms. The second pertinent system, respiratory, was also chosen due to the history of patient X. During her episode, she always experiences heart palpitations and hypertension, and experiences shortness of breath due to her high blood pressure of 140/95 during this time. According to the American Heart Association, nervous system problems can cause difficulty in breathing if the portion of the brain that regulates respiration is affected. However, neurological symptoms usually precede shortness of breath. In relation to heart problems as well, any problem with pulmonary circulation from the heart can cause shortness of breath, accompanied by chest pain. In relation to the symptoms of the patient, her shortness of breath is a probable cause of her heart palpitations and hypertension, causing her to breathe more quickly and more shallow in order to keep her blood oxygenated. The respiratory exam also parallels with the peripheral vascular exam when inspecting the outer extremities, which were cold to the touch, but otherwise normal. Thank you for listening.